As we know, the scalp has 5 layers. The outermost is skin, then the connective tissue, then epicranial aponeurosis, loose areolar tissue, and pericranium. Scalp is of great clinical significance, and each layer has got its clinical implication, but in this slide we will restrict ourselves only to the surgical importance of scalp. So the first 3 layers of the scalp, that is skin, connective tissue and epicranial aponeurosis, are intimately united, and the loose areolar tissue allows first 3 layers to move over pericranium. In surgical incisions, first 3 layers are separated from pericranium and they are termed as surgical layer of scalp. Also, the scalp is supplied by 10 arteries which enter from periphery into second layer of scalp. So during craniotomy, flap should be turned downwards and they should have broad pedicles to maintain arterial supply. Then the third importance is blood clot between pericranium and calvaria over parietal bone due to rupture of periosteal arteries during birth is known as cephalohematoma. Fourth layer of scalp is loose areolar space. It contains Walde's emissary veins. Emissary veins connect intracranial venous sinuses with extracranial veins. So the site where the emissary veins connect the intracranial venous sinuses with extracranial veins are of clinical significance, and they are: first site is emissary vein of foramen cecum. It connects vein of frontal sinus and root of nose to superior sagittal sinuses. Then the ophthalmic vein connects supraorbital and supratrochlear veins with cavernous sinus. Third site is parietal emissary veins. They connect veins of scalp with superior sagittal sinus. Then the mastoid vein connects posterior auricular vein with transverse sinus. Hypoglossal veins connect neck veins with transverse sinuses. Condylar canal veins connect deep veins with transverse sinus. Then the veins of foramen lacerum connect pterygoid venous plexus with cavernous sinus. Emissary veins of foramen ovale connect pterygoid plexus with cavernous sinuses. The veins of Vesalius connects pterygoid plexus with cavernous sinus. And 10th is the middle meningeal vein. It connects pterygoid veins with cavernous sinus. Thus, these Walde's emissary veins spread infection from extracranial to intracranial venous sinuses. Slide is of Bell's palsy. So, in the Bell's palsy, there is lower motor neuron or infranuclear lesion of facial nerve supplying muscles of face. It occurs due to viral infection. There is edema and compression of facial nerve in facial canal or stylomastoid foramen. Now we will see what are the symptoms and what is the anatomical basis for it. So in case of lower motor neuron or infranuclear lesion of facial nerve known as Bell's palsy, it affects upper as well as lower quarter of same side, that is ipsilateral side. So first symptom is the facial asymmetry is there due to unopposed action of muscles of opposite side. Then loss of wrinkles on forehead due to paralysis of fronto-occipitalis. Inability to close eye due to paralysis of orbicularis oculi. Inability to move angle of mouth upwards and laterally due to paralysis of zygomaticus major. Then loss of nasolabial furrow due to paralysis of levator labii superioris alegnesi. The food accumulates in vestibule of mouth due to paralysis of buccinator, and there is dribbling of saliva due to paralysis of orbicularis oris. Inability to inflate cheek properly due to paralysis of buccinator. So this is all about Bell's palsy. Now, if the lesion occurs at upper motor neuron or if there is supranuclear lesion of facial nerve, injury to corticonuclear fibers as a part of hemiplegia, only lower quarter of contralateral side of the face is paralyzed. The upper quarter escapes due to bilateral presentation in cerebral cortex, and here only voluntary movements are affected. Deep facial vein communicates with cavernous sinus through angular vein. Any infection of region of face drained by facial vein can cause cavernous thrombosis. During dissection of facial artery near the margin of mandible, dissecting too close to the artery can damage facial vein. This is important when the facial vein is harvested for venous drainage in facial transplantation. The facial vein is ligated and cut when dissecting out submandibular gland. So this is surgical importance of deep facial vein. Parotid gland contains three structures in it from superficial to deep. There are 5 facial nerve branches. Then there is retromandibular vein and external carotid artery. In parotid abscess, it is drained by small horizontal incision known as Hilton's method in parotid fascia to avoid injury to horizontally radiating branches of facial nerve. During parotidectomy, facial nerve is preserved by removing the gland into superficial and deep parts separately. Is of Frey syndrome. When penetrating wound in parotid region cuts auriculotemporal and great auricular nerve, during the process of regeneration, the parasympathetic secretomotor fibers of auriculotemporal nerve destined to supply parotid gland grow out, and it joins with the fibers of great auricular nerve meant to supply sweat glands. Consequently, when the person eats, a stimulus intended for saliva production produces sweat secretion. Slide is of wry neck or torticollis. Torticollis is deformity in which the head is bent to one side and chin points to other side as a result of spasm or contraction of sternocleidomastoid and trapezius muscle supplied by spinal accessory nerve. Common types of torticollis are rheumatic torticollis due to cold, reflex torticollis due to inflamed cervical lymph nodes, congenital torticollis due to birth injury. Wry neck is shortening of muscle fibers due to intravascular clotting of veins within the muscle, and it occurs during difficult delivery of the baby. This slide is of clinical importance of dural venous sinuses. First, we will see what happens when there is cavernous sinus thrombosis. Mostly cavernous sinus thrombosis is caused by sepsis in dangerous area of face, nasal cavity, paranasal sinuses. There is severe pain in eye and forehead in the area of distribution of ophthalmic nerve, and involvement of third, fourth and sixth cranial nerve causes paralysis of extraocular muscles supplied by it. There is edema of eyelids, cornea, root of nose. Exophthalmos occurs due to congestion of orbital veins, and communication between cavernous sinus and internal carotid artery may cause eyeball protrusion and pulsation. It is known as pulsating exophthalmos. Then the superior sagittal sinus thrombosis causes spread of infection from nose, scalp and diplopy. There is defective absorption of cerebrospinal fluid and raised intracranial tension. Then delirium, convulsions due to congestion of superior cerebral veins. Also, paraplegia of upper motor neurons due to bilateral involvement of paracentral lobule of cerebrum, where the lower limb and perineum are represented, and thrombosis of sigmoid sinus secondary to otitis media or mastoiditis can occur, and there is spread of infection or thrombosis from sigmoid and transverse sinus to superior sagittal sinus. It causes impaired cerebrospinal fluid drainage and hydrocephalus, and the condition is known as otitic hydrocephalus. Slide we will see the effect of pituitary tumors on visual pathway. So the pressure applied by pituitary tumor mostly involves optic chiasma, then the optic nerve and optic tract before affecting the cranial nerves. So pressure of pituitary tumor on central part of optic chiasma typically causes bitemporal hemianopia. If there is compression of optic nerve, it causes double vision, or there may be loss of vision and drooping eyelid. The pituitary macroedemas, if they affect the optic nerve or optic chiasma or optic tract, the symptoms or the signs and symptoms will be different. And pressure of pituitary macroedema on central part of the optic chiasma, as told before, causes bitemporal hemianopia. So this, in this bitemporal hemianopia, there is loss of peripheral vision, so it is also known as tunnel vision. And if there is involvement of optic nerve, it causes ipsilateral total blindness, and involvement of optic tract causes homonymous hemianopia. So it mostly involves, means there is loss of vision in the geniculate body temporal field of the opposite eye, and nasal or optic radiations of ipsilateral eye are involved, and there is without macular sparing. This slide is of Horner syndrome. So Horner syndrome is ipsilateral oculosympathetic paralysis due to lesion of ascending cervical sympathetic ganglion. If we confine ourselves only to the anatomical basis of the signs and symptoms of Horner syndrome, we will see one by one the signs and anatomical basis for that. So, first is due to paralysis of Mueller's muscle, that is part of levator palpebrae superioris supplied by oculomotor nerve. When the nerve is injured, it causes drooping of upper eyelid. It is known as ptosis. So the first sign of Horner syndrome is ptosis or drooping of eyelid. Then, due to palsy of dilator pupillae and unopposed action of constrictor pupillae, there is meiosis. Meiosis means constricted pupils. Then the third sign is due to palsy of orbitalis muscle, which helps to maintain normal position of eyeball in the orbit. So there is inophthalmos or sunken eyeball. Due to involvement of sympathetic innervations of sweat gland, there is loss of sweating or anhidrosis, and loss of ciliospinal reflex. Ciliospinal reflex means if we pinch the skin of nape of the neck, uh, it does not produce dilatation of pupil when there is loss of ciliospinal reflex. So these are the signs and symptoms of Horner syndrome and anatomical basis for it. In this slide we will see the anatomical basis of paralysis of muscles supplied by oculomotor, trochlear and abducent nerve along with strabismus. So we know that these three nerves mainly supply the extraocular muscles. So if the third cranial nerve, that is oculomotor nerve, is injured, then there will be dilatation of pupil due to paralysis of constrictor pupillae and unopposed action of dilator pupillae. Loss of accommodation reflex due to paralysis of ciliary muscles, partial ptosis or drooping of upper eyelid due to paralysis of levator palpebrae superioris. Then the trochlear, when the fourth cranial nerve is injured, then there is paralysis of superior oblique muscle. It results in the inability to turn eyeball downward and laterally. If patient attempts to do this, affected eye is rotated medially, resulting in diplopia, that is double vision, and involvement of abducent nerve produces paralysis of lateral rectus muscle, and it results in medial convergent squint and diplopia. Thyroid gland is enclosed in pretracheal layer of deep cervical fascia, and this fascia is attached to hyoid bone and thyroid cricoid cartilages through ligament of Berry, which is derived from pretracheal layer of the deep cervical fascia. It connects thyroid gland with cricoid cartilage. So during swallowing, the thyroid swelling moves up and down with larynx being fixed to the cartilage by pretracheal fascia. Thyroid growth is limited upwards by sternothyroid muscle attached to the oblique line of thyroid cartilage, and thus any swelling of the thyroid gland grows downwards. Then enlarging gland tends to push structures deep to it, and if there is compression of trachea, it leads to dyspnea, that is difficult breathing. Compression of esophagus leads to difficulty in swallowing, known as dysphagia, and compression of recurrent laryngeal nerve leads to dyspnea or hoarseness of voice. So these are anatomically relevant clinical features of thyroid swelling. Pterygoid venous plexus returns blood to the heart during contraction of lateral pterygoid muscle. So this pumping action of blood back to the heart is by the lateral pterygoid. The pterygoid venous plexus collects blood from palate, nasal cavity, paranasal sinuses, nasopharynx, auditory tube, and this pterygoid venous plexus communicates with cavernous sinus, then pharyngeal sinus through foramen ovale, foramen spinosum and foramen rotundum. So it has potential to spread dental infection. It can be penetrated when administering block injection of posterior superior alveolar nerve, and it resulting in hematoma. So this is clinical significance of pterygoid venous plexus. Slide is of submandibular stones. So salolithiasis is a benign condition involving formation of stones within the ducts of major salivary glands, that is parotid gland, submandibular and sublingual glands. So saloliths, or the stones in the salivary glands, obstruct ducts. Superimposed bacterial infection is known as salidinitis. It causes abscess formation, and large stones involving distal part of Wharton's duct or Stenson's duct are diagnosed by radiological procedure known as salography, and causes either duct stenosis or inflammation affecting the flow of saliva, or altered composition, mainly increase in the calcium content, may cause stone formation. Among the three salivary glands, submandibular salivary gland is most common site of silolithiasis because of its mucus and alkaline nature. and high calcium concentration. Also, the Wharton's duct is longer and of large caliber, so slower salivary flow rate is there. As the saliva flows against gravity, stone formation is more common in submandibular gland. During thyroidectomy, superior thyroid artery is ligated near the gland to save external laryngeal nerve, and inferior thyroid artery is ligated away from the gland to save recurrent laryngeal nerve. Again, the next anatomical aspect to be discussed here is the dense capillary plexus is present deep to the true capsule. So, to avoid hemorrhage during operation, thyroid is removed along with the true capsule. Whereas in case of prostate, the venous plexus lies between the true and false capsule. So, both the capsules are left behind during prostatectomy. Then the posterior strip of thyroid gland is left behind during thyroidectomy to avoid damage to the parathyroid gland. Enlarged and infected tonsils are surgically removed by tonsillectomy by Guillotine method. So, hemorrhage after tonsillectomy is checked by removal of clots from raw tonsillar bed, similar to the checking of postpartum hemorrhage from uterus. So, uterus and tonsil are the only two organs in the body where bleeding is checked by removal of clots. In other parts of body, clot formation is encouraged. In relation to the nasopharyngeal isthmus, there are several aggregation of lymphoid tissue forming Waldeyer's lymphatic ring, which forms a defense system to prevent spread of infection from oral, nasal, and respiratory tract. Laterally, there is right and left palatine tonsil, and superiorly nasopharyngeal tonsils are there, inferiorly there is lingual tonsil, and hypertrophy of nasopharyngeal tonsils may obstruct the posterior nasal aperture and interfere with respiration and speech, and hypertrophy of tubal tonsils may occlude auditory tube leading to middle ear problem. An infection of tonsils is known as tonsillitis. It is site of septic foci where suppuration can occur and it can spread to the peritonsillar area, which is known as quinsy. On each side of laryngeal inlet, the lateral wall of pharynx presents a recess known as pyriform fossa. Underneath the floor of the pyriform fossa, internal laryngeal nerve and vessels are present. Foreign body entering in the pharynx like safety pin, fish bone, etc. may lodge in the pyriform fossa. If it is sharp, it may pierce the mucous membrane of the floor and injure internal laryngeal nerve supplying supraglottic portion of laryngeal cavity and causes anesthesia over that region. Pyriform fossa is also known as smuggler's fossa. Smugglers manipulate to increase the dimension of fossa by using lead balls to hide smuggled items like diamonds. So it is also known as smuggler's fossa. Hypertrophy or enlargement of nasopharyngeal tonsil or adenoids may obstruct the posterior nasal aperture and interfere with nasal respiration and speech, leading to mouth breathing. These tonsils regress by puberty normally. There is a typical appearance in adenoid hypertrophy. It is known as adenoid faces. So in chronic cases, child is forced to breathe through mouth, ala of the nose fail to develop properly, open mouth with protruding tongue gives dull expression, and pinched nose is known as adenoid faces. Then the inflammation of the tonsils, uh, it acts as a septic foci and it may lead to suppuration of peritonsillar space It is known as quinsy. So it is drained by making incision in most prominent point of the abscess, and the peritonsillar abscess causes pain, swelling, blockage of throat, difficulty in swallowing, speaking and breathing. Thus it is drained by making an incision over the abscess. Inferior constrictor muscle of pharynx is made of upper oblique thyropharyngeus and lower transverse cricopharyngeus part. Posteriorly, there is a potential gap between the two components of inferior constrictor muscle, and this is known as Killian's dehiscence. So the mucosa and the submucosa of pharynx may bulge through this weak area to form pharyngeal diverticulum, and neuromuscular incoordination of two parts of inferior constrictor causes this condition. So propulsive thyropharyngeus is supplied by pharyngeal plexus, and sphincter cricopharyngeus is supplied by recurrent laryngeal nerve. If cricopharyngeus fails to relax when thyropharyngeus contracts, the bolus of food fails to move downwards, and instead it is pushed backwards in the region of Killian's dehiscence, producing pharyngeal pouch filled with food, causing dysphagia. This condition is known as pharyngeal diverticulum, which occurs due to Killian's dehiscence. In all, there are five pairs of paranasal sinuses. So there is frontal sinus, ethmoid sinus, sphenoid sinus, maxillary sinus, and mastoid sinus. Sinusitis is inflammation of mucosa of paranasal sinuses. If frontal sinus is involved, then frontal sinus is closely related to the frontal lobe of brain. So frontal sinusitis can cause frontal lobe abscess. Maxillary sinus is infected from nasal cavity or caries of upper molar teeth. Maxillary sinusitis is more common because its opening in nasal cavity is located much higher than the floor with poor natural drainage, and maxillary sinus or antrum of Highmore drains into middle meatus of lateral wall of nasal cavity in superior part of the base at the top of sinus. When the sinus contains mucus or pus, it cannot be drained into nose with erect head until sinus fills up to the opening drainage of maxillary sinus may require antral puncture by passing trocar and cannula through the nasal cavity below inferior nasal concha. Medial wall of the sinus is fenestrated in Cadillak operation. In acute maxillary sinusitis, pain derived from posterior, middle, anterior, superior alveolar nerves pass through maxillary molars and premolars, and it causes referred pain. In maxillary carcinoma, there is invasion of surrounding anatomical structure. So medial invasion causes nasal obstruction and epistaxis, epiphora due to blockage of nasolacrimal duct. Superior invasion in the orbit displaces eye, causing diplopia. Inferior invasion causes ulcerations in palatal roof. Lateral invasion produces swelling of face or gingivolabial fold. Posterior invasion may involve palatine nerves referred to the upper teeth. Sinusitis may occur due to inflammatory edema of nasal mucosa or polyps or deviated nasal septum or poor ciliary action. Thick sticky mucosa is there in condition like cystic fibrosis. So these are some of the causes of paranasal sinusitis. Inflammation of larynx or vocal box due to overuse, infection, or irritation causes hoarseness of voice. The larynx can be examined by a procedure known as laryngoscopy. By laryngoscopy, one can inspect the base of tongue, then vallicula, epiglottis, epiglottic fold, pyriformis fossa, and the vestibular folds and vocal folds. When both the recurrent laryngeal nerves are interrupted, vocal cord lie in cadaveric position in between abduction and adduction, and phonation is completely lost. Deep breathing also becomes difficult through partially opened glottis. When one recurrent laryngeal nerve is paralyzed, opposite vocal cord compensates for it and phonation is there with hoarseness of voice. There is failure of forceful explosive part of voluntary and reflex cuffing. Cuffing is again not possible. Then mediastinal tumors may press on the left recurrent laryngeal nerve, altering the voice. Right recurrent laryngeal nerve is given off in the neck, so it is not affected by mediastinal syndrome. Hypoglossal nerve supplies all the intrinsic and extrinsic muscles of the tongue in one half of the tongue, except palatoglossus. Palatoglossus muscle is supplied by pharyngeal plexus. So, if the hypoglossal nerve is damaged, tongue deviates towards the side of paralysis when protruded due to the unopposed action of muscles of opposite side. If right hypoglossal nerve is damaged, the tongue will be deviated to right side. Further, there is hemiatrophy of right side of the tongue. Cataract is an opacity of lens resulting from built-up proteins. Lens of the eye is normally transparent and biconvex. Lens consists of layer of cuboidal epithelial cells confined to anterior region of lens and the lens fibers which are confined to posterior region. These fibers are derived from cuboidal epithelial cells of anterior region and the cuboidal epithelial cells proliferate and give rise to lens fibers at the equator of lens. Older fibers of the lens lose their nuclei and cellular organelles and accumulate crystalline proteins. The central part of the lens, that is nucleus, is harder than peripheral part. Peripheral part is known as cortex and central part is known as nucleus. And as the age advances, the protein built up within lens makes it opaque, and this opacity of the lens is known as cataract. Lens also becomes harder, flat, with decreased focusing power. There is loss of accommodation known as presbyopia, and the defect may be overcome by use of convex lens. And cataract is treated by surgical removal of the lens. It is known as cataract extraction and implanting artificial lens. Glaucoma is the disease of eye characterized by raised intraocular pressure. If untreated, it can damage retina and optic nerve. It is one of the leading cause of blindness. As we all know, the eye is divided into two major compartments. We can see it in the diagram also. So, a large posterior compartment is there which lies posterior to the lens and small anterior compartment which lies anterior to the lens. So, there are anterior and posterior compartment. Anterior compartment is further divided into two chambers. Anterior chamber lies between cornea and iris and the posterior chamber lies between iris and lens. So these two chambers are filled with aqueous humor which helps to maintain intraocular pressure. Aqueous humor is produced as the blood filtrate in the posterior chamber by ciliary process. From here it passes through the pupillary aperture into anterior chamber, where it is reabsorbed by ciliary veins by sinus venosus sclerae. So there is canal of Schlemm. It is a venous ring at the base of cornea, and production and removal of aqueous humor results in circulation of aqueous humor and maintain the constant intraocular pressure. If there is overproduction of aqueous humor or defective absorption of it due to blockage of canal of Schlemm, then the excessive accumulation of aqueous humor within the eye causes increased intraocular pressure, and this is known as glaucoma. Retina receives dual blood supply. Inner part of retina is supplied by central artery of retina, and outer retina or outer part of the retina is supplied by choroidal circulation via posterior ciliary artery. Both the sets arise from ophthalmic artery. Ophthalmic artery is the first branch of internal carotid artery as it exits the cavernous sinus. Ophthalmic artery passes through optic canal inferolateral to the optic nerve, and on entering the orbit, central artery of retina travels within the optic nerve, after which it enters the eye, where it is subjected to intraocular pressure changes. So the central artery of retina gets occluded in, and this is an ocular emergency with profound acute painless monoocular vision loss. So ipsilateral carotid artery atherosclerosis is the most common cause of central retinal artery occlusion. Slide has two figures. First is of otitis externa and second is of otitis media. So first we'll see what is otitis externa. Normally the external auditory canal is 2.5 centimeter long. Its outer one third is cartilaginous with small amount of subcutaneous tissue appendages like hair cells, sebaceous glands and apocrine glands known as apopilosebaceous unit. Now medial two-third is osseous and skin lining is 0.2 millimeter thick with no subcutaneous appendages. Tympanic membrane is fibroelastic membrane with three layers: epidermic, fibrous, mucus. It is divided into pars flaccida and pars tensa, and it separates external ear from middle ear. So in case of otitis externa, there is acute or chronic infection of whole or a part of skin of external ear canal, and organisms enter in the apopilosebaceous unit by breaking the skin, commonly by fingernail or when we are relieving itching by fingernails. Then periosteal lining of bony canal is displaced by swelling, and there is pain, itching, fullness, then hearing loss. There can be necrotizing or malignant otitis externa also, which is life threatening. Cause is osteomyelitis of temporal bone or spread via fissure of Santironi or tympanomastoid fissure. So there is granulation tissue in external ear. Then keratosis obturans is accumulation of desquamated epithelium in bony canal. It may be associated with sinusitis, bronchiectasis, or primary ciliary dyskinesia. It usually causes deafness and pain. Then bullous myringitis is inflammation of lateral surface of tympanic membrane and medial portion of canal wall, and it is associated with upper respiratory infection. Then the second slide is of otitis media, and it is acute infection of mucous membrane lining the middle ear cleft, and the root of infection is either eustachian tube or external auditory canal. It can be blood borne and it causes discomfort, autophony, then there is fever, earache, there can be deafness and bulging of the tympanic membrane. Tympanic membrane may rupture, causing otorrhea in otitis media. Tympanic membrane is incised to drain pus present in middle ear. The procedure is called myringotomy, and the incision for myringotomy is made in posterior-inferior quadrant of the membrane where bulging is most prominent. In giving an incision, it is to be noted that chorda tympani runs downwards and forwards across inner surface of tympanic membrane, lateral to the long process of incus, medial to the neck of malleolus. If the nerve is injured, the taste sensation from anterior two-thirds of the tongue is not perceived. Also, the saliva from submandibular and sublingual gland gets affected. Cerebral angiography is radiological technique to visualize the arteries of brain in living persons. Radioopaque medium is injected into the lumen of common carotid or vertebral arteries by inserting catheter into radial and femoral arteries. A series of films, both in antero-posterior and lateral view, are taken after injecting the radioopaque medium, depending on whether internal carotid artery or vertebral arteries are used. The radiographs are known as carotid angiogram and vertebral angiogram, respectively. So the radiographs reveal pattern of cerebral arteries, capillaries, and veins. Cerebral angiography is done to visualize abnormalities of blood vessels, then space occupying lesions, vascular pattern of tumor. CT scan and MRI are alternately used instead of invasive technique of cerebral angiography nowadays. Slide is of cervical lymph nodes. We can classify the cervical lymph nodes of head and neck region as superficial nodes and deep nodes. The first figure of this slide shows all the superficial cervical nodes. They are mainly submental nodes, submandibular nodes, buccal and mandibular, preauricular or parotid, postauricular or mastoid, occipital, anterior cervical and superficial cervical lymph nodes. So first is the submental node. These are 3 to 4 in number, situated in midline in the submental triangle below the chin. Submandibular lymph nodes are usually 3 to 4 in number, situated in submandibular triangle in contact with the surface of submandibular gland. Then the mandibular nodes are at the lower border of mandible near the antero-inferior angle of masseter in relation with the mandibular branch of facial nerve. Buccal nodes lie on the buccinator muscle. They drain part of cheek and lower eyelid. Then the parotid or preauricular lymph node. They lie partly in the superficial fascia and partly deep to the deep fascia over the parotid gland, and they drain the temple region, then side of the scalp, lateral surface of the auricles, external acoustic meatus, middle ear, parotid gland, upper part of the cheek, part of eyelids and orbit. Then the postauricular lymph nodes or mastoid nodes lie on the mastoid process, superficial to the sternocleidomastoid and deep to auricularis posterior. They drain a strip of scalp just above and behind the auricle and the upper half of the medial surface of margin of auricle and posterior wall of external acoustic meatus. The next group is occipital nodes. They lie at the apex of posterior triangle, superficial to the attachment of trapezius, and they drain occipital region of the scalp. Then the pretracheal and pre-laryngeal group of lymph nodes lie deep to the investing layer of deep cervical fascia. The pre-laryngeal nodes on the cricothyroid membrane and pretracheal in front of the trachea below the isthmus of thyroid gland drain the larynx, trachea and isthmus of thyroid. After that we have deep cervical lymph nodes. So they are jugulodigastric, jugulo-omohyoid, and we have infrahyoid nodes, retropharyngeal nodes, and lymph nodes surrounding the internal jugular vein. So, so the second figure of this slide has deep cervical lymph nodes. The entire lymph from head neck region drains ultimately into deep cervical nodes, and they form a vertical chain situated along entire length of internal jugular vein. So mainly we have jugulodigastric nodes which forms upper deep cervical node, and the jugulo-omohyoid nodes are the lower deep cervical nodes. Jugulodigastric nodes lie below the posterior belly of digastric between the angle of mandible and anterior border of sternocleidomastoid, and it is the main node draining tonsils. Then the lower deep cervical is jugulo-omohyoid node. It lies just above the intermediate tendon of omohyoid under cover of posterior border of sternocleidomastoid, and it is the main lymph node draining the tongue. Then the significance of cervical lymph node are, there are three basic classes of lymph node. First is fibrotic nodes. They are palpated as scarred jelly bean like structures. They are freely movable and they escape from clinician's finger, so they are usually representative of previous infection. Then the second group is of tender, enlarged, inflamed nodes. These are indicative of active infection. And the third variety is stony hard fixed node. They feel like marbles that cannot move from underlying structure, and they usually represent some kind of neoplasia. Now, there are levels of the lymph node in the deep in the cervical region. So, as shown in the figure, the first level lymph nodes are submandibular and submental. Then second level has superior spinal, accessory superior jugulo-digastric. Third level is mid-jugular, jugulo-omohyoid, and inferior jugular forms fourth level. In the fifth level, the lymph nodes are of the posterior triangle, that is inferior spinal, accessory and transverse cervical. Then sixth is pretracheal and paratracheal lymph nodes, and seventh level is of mediastinum, the lymph nodes of mediastinum, mainly infraclavicular and anterior mediastinal. So the level of lymph nodes is important in case of metastasis.